Okay, it had to be closed down and opened again. All right, apologies for the delay. So my task this afternoon, I guess by most of your watches, is to discuss the initiation of therapy in Parkinson's disease, pharmacological therapy in Parkinson's disease. So the treatment of Parkinson's disease can be subdivided in very broad terms under these three categories. In an ideal world, when we make a diagnosis of Parkinson's, we would initiate disease-modifying therapy. But unfortunately, as I'll point out briefly, we don't have effective protective or disease-modifying treatment. We do have extremely effective symptomatic therapy, and unfortunately nothing that restores the neuronal loss at this point. So if you've read algorithms in the management of Parkinson's, this is a very old one. Today's talk is going to concentrate on the upper part of the algorithm in how to initiate treatment in Parkinson's disease. So let's start with non-pharmacologic therapy, which is obviously extremely important and shouldn't be forgotten, although it's not going to be the main concentration of the talk, with education, support, exercise, nutrition. What about exercise and physiotherapy? Well, there's been a lot of discussion about when physiotherapy and occupational therapy should be initiated. Although this trial, led by Carl Clark, was negative, this used a standard form of physiotherapy that would be applied by occupational physiotherapists in the community and really didn't show benefit. The critics of this study emphasize that if it's going to be effective, it really needs to be disease tailored and knowledgeable about the disease. So this remains uncertain. There is a lot of interest in high intensity exercise, and this was a study that just looked at the feasibility of very intensive exercise in patients with Parkinson's and showed that it was quite safe and feasible. And so I think we're going to see in the future studies that look at this question, but right now we just don't know. So let's come back to the algorithm and ask the first question. As I've mentioned, do we have effective disease-modifying therapy? Because that would be the way we would initiate any therapy in a neurodegenerative disease. Unfortunately, we've seen a large number of negative neuroprotective trials. This is a list of all the drug names, with the most recent announcement of cinpanemab, the monoclonal antibody for alpha-synuclein, being ineffective. All of the proposed mechanisms of action with multiple different trial designs, unfortunately with a lot of tombstones and many millions of dollars spent in Parkinson's. But that doesn't mean we've stopped, and so there are many other treatments coming along. You're probably aware of the tremendous hope for the monoamine oxidase B inhibitors. Rasagiline was the most recent one studied in a delayed start design, with some patients receiving placebo in the early weeks and others receiving active treatment. Patients received two different treatments or two different doses. This was the result of the 1 milligram, showing that at the end of the trial, there was a very significant difference between those receiving the active treatment versus the placebo. And this looked very promising. However, the 2 milligram higher dose was negative, and this created a lot of confound. And still, it's not clear why this was, with some suggestion that maybe the more potent symptomatic effect masked any protective effect. However, unpublished data from the follow-up of patients participating in the Adagio trial, over almost 700 patients participated in this follow-up, 88% remaining on Adagio or remaining on Rasagiline, and unfortunately, there was no difference in really important milestones of interest in long-term follow-up after 3 years. So there was no difference in the emergence of gait problems, balance problems, falls, freezing, and cognitive decline. And so this, I think, tells us that there probably isn't any important disease-modifying effect of this treatment. Again, that doesn't mean that we've stopped, and this is a list of a large number of studies that are active in humans. There are many preclinical treatments that I think you're going to hear about from Dr. Shapiro, but at least at this point, we have a number of trials that are still active in patients with Parkinson's with still a great deal of hope. So let's come back to our algorithm and come to the next question. When we have a patient who lacks functional benefit, or functional impairment, I should say, should we continue just simply to monitor them, or should we be doing something different? There have been a couple of studies that tried to address this, published quite a while ago now, in 2007 and 2008, both in JNNP, with very different results. In this trial, studied or led by Professor Grosset, the patients who did not receive symptomatic therapy, these are patients in both studies who the physician and the patient felt were doing well and could have continued to be simply monitored with a wait and watch strategy. In this first study, those that received symptomatic therapy had a better quality of life. So those not receiving therapy had a poorer quality of life than those that received treatment. On the other hand, in this study, exactly the same design, they came to a different conclusion with an equivalent quality of life. However, if you read the details, surprisingly, those that were untreated progressed by 12 points on the Unified Parkinson's Disease Rating Scale, more than the treated patients. And I have a lot of difficulty understanding how that doesn't equate to a change and a worsening of quality of life. Now, in the LEAP trial that I was a part of, led by Rob DeBee, one of my previous fellows from the Netherlands, this was an early delayed start trial of levodopa versus placebo. The only point to show you on this issue is the fact that in those patients receiving early levodopa, even though, again, these patients were felt to be doing fine and didn't need symptomatic therapy, in fact, there was a significant difference between the two on a quality of life measure. So now let's come to the next issue, is initiating dopaminergic therapy. Now our patients need therapy. How should we do that? And there's always been a concern about delaying levodopa, and an argument that this is the best approach because maybe it's neurotoxic. Well, there's actually no evidence whatsoever for neurotoxicity of levodopa currently, although there is still some question raised in the basic science or preclinical models. There is a concern really voiced by a lot of patients as well as doctors that levodopa loses its clinical effect over time. But we now know that levodopa is effective even after patients have the disease for 30 years or more. It's really that the disease changes and the disease is no longer purely dopaminergic. However, it's the motor complications then that really underlie the arguments for the potential that we should delay levodopa. So how should we treat if we're not going to use levodopa? Well, should we use monoamine oxidase B inhibitors? Well, I've already told you there's no evidence for them being neuroprotective. They only have minimal to modest benefit. In some patients, that benefit is negligible. And when you initiate these treatments, it's pretty rare that you delay the need for other symptomatic therapy for beyond 6 months. Most patients still require symptomatic therapy sooner rather than later. What about the relative efficacy of these MAO-B inhibitors? There's no head-to-head evidence. However, this meta-analysis comparison, when the data was compared using the drugs alone, rasagiline seemed somewhat better than selegiline, and both of these agents seemed better than the newer MAO-B inhibitor, safinamide. When the drugs were used with levodopa, there was somewhat different results, with selegiline and rasagiline still being the better. Okay, so let's then come to the issue of motor complications and that big concern about the need for delaying levodopa. Well, in fact, there is very good reason for being concerned. This is the L-DOPA trial. This was a delayed start design, or at least an early versus late levodopa therapy, levodopa versus placebo. And in the highest dose of levodopa group, within 9 months, 15% of patients had levodopa-induced dyskinesia. So this is not an uncommon or significant problem. And the question is, how does that happen? And you may be aware of the fact that even at the earliest stages, levodopa plasma levels rise and fall because of the very short half-life of levodopa. But in the brain, we believe, because of the buffering capability and the storage capability that the brain has in patients with mild disease, there is a more continuous release of levodopa. But with time, we see the dopamine receptors challenged with an effect that is non-continuous and pulsatile. And so this pulsatile effect may have an impact on causing dyskinesia, with the hope then that maybe if we could provide the brain with a more continuous stimulation, we may be able to delay these problems. So is continuous dopaminergic stimulation possible in patients with Parkinson's disease using available levodopa formulations or other dopaminergic therapies? Well, what about controlled release levodopa or CR levodopa? Very poorly bioavailable, no evidence that we can delay motor complications. What about the formulation available in the United States, Rytary, that combines rapid versus slow release? There is absolutely no evidence or studies that have looked at this question. What about using COMT inhibition? At least with the more widely available COMT inhibitor, entacapone, there is no evidence whatsoever, and indeed a negative study called the STRIDE PD study. So then, what about using dopamine agonists to try to prevent these motor complications? Well, there's been a lot of data arguing that we might use these preferentially in early therapy to delay levodopa complications. These are Kaplan-Meier curves drawn in different ways, either up or down, using 4 different dopamine agonists, all showing evidence that levodopa complications, particularly dyskinesias, can be delayed when we use dopamine agonists versus levodopa. And this is a meta-analysis of all of the data showing quite good evidence that we can delay levodopa-induced dyskinesia using a variety of dopamine agonists. However, we know that dopamine agonists are less clinically effective than levodopa. The effects may be strongly influenced by the patient's age. So elderly patients may have much less benefit in delaying levodopa-induced motor complications than younger patients. And once levodopa is started, which is inevitable in all of these patients, having been treated with an agonist early on, you're not protected from developing these problems. The clock gets set and you start developing them as you would have otherwise. The most important argument, though, is that all of the evidence that I've shown you to date, the meta-analysis, demonstrates a delay in early, much milder and non-disabling levodopa-induced motor complications, particularly dyskinesia. What about after 5 years when they start to be problematic? Well, there's not a lot of really good evidence on this. One of them is the PD Med trial from Britain, where quality of life was the major outcome variable. And in this study, levodopa benefited patients more than levodopa-sparing therapies, dopamine agonists, and monoamine oxidase B inhibitors. The difference was mild but significant. And most importantly, the difference was significant despite the clear development of dyskinesia more in the levodopa-treated group versus the levodopa-sparing group. So even though you don't get dyskinesia to the same extent, you still have a better quality of life receiving levodopa. So there are a number of advantages that were shown in this study. However, one of the biggest problems in the study is that very few patients under the age of 60 were studied. The important question then that I've emphasized is that although we have these arguments, we don't have a lot of good data beyond 5 years. What is the data we have? Well, there have been 3 longer-term studies at 6, 10, and 14 years of follow-up with different dopamine agonists, ropinirole, bromocriptine, and pramipexole. And generally, these studies have shown very little advantage when it comes to longer-term follow-up. What about the question of whether dyskinesia has actually been overemphasized? Well, there's still back and forth argument about this issue. We have to admit that levodopa-induced dyskinesia remains one of the commonest reasons that people require advanced therapies, for example, deep brain stimulation. But this is a study from the Mayo Clinic that was published several years ago. Dyskinesia being very clearly a problem in patients taking levodopa over many years. However, when we look at the requirement for medication adjustments or the occurrence of dyskinesia that were resistant to medication adjustments, these are far less common. Also, when we look at the results of the Sydney multi-center study by Helly and her colleagues, at 15 years, a very high proportion of patients had end-of-dose failure and levodopa-induced dyskinesia. However, these were non-disabling in the vast majority of patients. So it is possible that in many patients, these dyskinesias are not as much of a problem as you would have thought of. We'd prefer to treat patients without them by any means, for sure. So what about other arguments for using dopamine agonists instead of levodopa? Well, one of the biggest problems, as I'm going to emphasize now, is the occurrence of complications, and particularly the last two, excessive daytime sleepiness and this problem, impulse control disorders, which I think have really altered the way we use dopamine agonists, because we need to recognize that the biggest risk factor, the most significant risk factor, is the use of the modern dopamine agonists such as ropinirole, pramipexole, rotigotine, the D2/3 dopamine agonists, although some of these problems do occur less commonly with levodopa and apomorphine. In the Dominion study, that was a study we ran out of Canada and the United States, these problems, pathologic shopping, gambling, binge eating, and hypersexuality occurred with these frequencies. These seem rather low, and subsequent studies have really shown us that, in fact, we were underestimating these by a long shot in our Dominion study. This is a paper that was published now about 5 years ago, largely from Spain, showing almost a 40% incidence of the occurrence of these problems, maybe a little less frequent with transdermal rotigotine, although this hasn't been confirmed in other studies. This is a large study that came out of France, 46% 5-year cumulative incidence with a strong association with dopamine agonists. In this study, dose and duration were associated with no difference whatsoever between the dopamine agonists, although rotigotine was not used in this study. And in follow-up, the ICDs resolved typically on withdrawal of the drug, but 50% of patients still had this problem at 1 year. This is another long-term study, 46 patients followed over 8 years, 29 discontinued, 13 reduced, and 4 had a reduction in levodopa. The dopamine agonist withdrawal syndrome was seen in about 16%, and these were the outcomes. So this remains a significant problem, although a high proportion do become asymptomatic. A very important proportion remain disabled by this problem. So let's come to some conclusions now as quickly as I can. When should we start dopaminergic or symptomatic therapy? Well, I've told you that it's not clear whether a wait and watch strategy does provide an advantage. I think we need better studies looking at this impact on quality of life. We have to remind ourselves that once levodopa is started, there is an important honeymoon period, and we don't know what the impact of delaying that is. This is an important study that I would like to tell you about, where patients in Italy were compared to patients in Africa and Ghana. Now, in Italy, obviously, the diagnosis is made earlier, and so Ghana, there is a longer term that the patient is symptomatic before the diagnosis is made. The patients start symptomatic therapy, in this case with levodopa, much earlier in Italy because the drug is more readily available. So there's a longer delay between the diagnosis and receiving symptomatic therapy. And then importantly, the honeymoon period, the time that the patient receives this treatment before they develop motor complications, is far longer in these patients in Italy compared to those receiving the treatment much later in Africa. And so the motor complications were associated with disease duration as well as daily dose, but not with duration of treatment. And so there's little evidence that withholding levodopa to delay motor complications is justified. And I think I'll skip this slide due to time. The question then is, how should we start treatment? Should we start the most potent versus modestly effective treatment, or maybe even combination therapies? There are people that would argue, let's start an agonist and levodopa. Well, there really isn't any clinical evidence to support that. I think we have to try to combat the problem that has really arisen in our field that both patients and physicians account for, and that is what has been termed levodopaphobia, the fear of the most effective therapy inappropriately. We need to balance the advantages of delaying dyskinesia with, for example, dopamine agonists compared to, or balance those with the results of long-term studies and the important acknowledgement of adverse effects. And acknowledge and recognize that age, duration of disease, dosage and weight, the underlying cognition, the presence of pre-existing addictive behaviors and others need to be considered. So it's very important to take all of this into consideration when we start symptomatic therapy. In the future, we're going to have to take into account increasing evidence, the need to maintain stable plasma levels, hopefully with new studies, and new studies that will look at neurorestorative treatments. And in the long term, we need better understanding of the disease, better animal models, and finally, and hopefully, effective disease-modifying treatments. Very quickly, in 2 minutes, I'm going to tell you about a paper that you're going to see that comes out of the Practice Guidelines Symptomatic Review and Recommendations for Treatment from the American Academy of Neurology. This is now in press in neurology. And a group of us evaluated these 4 issues of starting levodopa with recommendations to clinicians about whether we as clinicians must, should, or may use these various treatments. And I think I'll skip this slide because of time. I apologize for going over, but just these are the recommendations that are going to come out from the American Academy. When it comes to levodopa, clinicians should recommend immediately release levodopa as the initial preferential dopaminergic therapy. We should be prescribing this in the lowest dose and counseling patients about understanding and monitoring adverse effects, including dyskinesia. When it comes to dopamine agonists, clinicians may prescribe these, but only in selected patients, particularly those who are at higher risk of concerning motor complications. And I won't read through all of this, but this really emphasizes the need for clinicians to monitor, to inform patients, and to really be careful in the way we use these drugs because of the high incidence of these complications. And we should not be prescribing these in patients who are at much greater risk of these complications. And then with respect to MAOB inhibitors, we may prescribe them, but we need to counsel our patients of the greater motor benefit of the alternative therapies, particularly levodopa. And I'll stop at that point. Thank you for your attention, and I'm glad to address any questions if we've got the time.
Thank you very much indeed. If you could stop sharing your slides. Thank you. So we have 2 questions, both of which actually relate to impulse control disorders, which you also highlighted really in your talk. The first one is, what is your view on any pre-existing determinants that may predispose patients to impulse control disorders? Is it structural, genetic, or a complex interaction of both?
Great question. And the bottom line is that we don't know. This varies from study to study. Age plays a role, so the younger the patients, the greater risk. Clearly, the most important risk is the dopamine agonist. But beyond that, levodopa does contribute a little bit, but not strikingly, but it does contribute a bit. It also depends on the type of impulse control disorder. So males are more prone to hypersexuality, for example, and potentially gambling. Women are more prone to shopping and binge eating, but all sexes are at risk of these. There is some evidence of genetic predispositions. but these vary considerably from study to study. And there is some imaging data to suggest that there may actually be structural and even dopamine systems predispositions. However, most of this evidence is after the fact, studies of patients who have already developed dyskinesia rather than prospective studies. The prospective studies are only now beginning to come out. So we're hoping to see better results that would ideally give us the opportunity to do a battery of tests that then might predict who could be at risk of developing the impulse control disorders, and then allow us to use dopamine agonists more safely. I must admit, I'm misusing them. I should say misusing them rather than misusing them. So I think our patients could benefit, but I have seen so many lives ruined by these impulse control disorders that I am using them far less often than I ever used to.
And of course, we often don't recognize them until they have already developed for a while.
Yes. In many cases, patients are very embarrassed by these developments. And so I've seen many patients who we've questioned repeatedly on follow-up, who have denied the problem only to call us on an urgent basis when they have gambled away their second mortgage, or when their marriage is at risk because of the very severe hypersexuality and very dangerous behaviors that some of them have undertaken.
The second question was also on the impulse control disorders. What are your thoughts on those patients who do not recover from impulse control disorders after the medication is withdrawn? Is it that their disorder is an advanced manifestation of their PD rather than purely related to the dopamine agonist?
Well, as I said, other drugs can participate and contribute. These are related to dopaminergic stimulation in the brain, remembering dopamine is a reward neurotransmitter. And so in many of these patients, it's possible that the ongoing use of other dopaminergic drugs, levodopa, for example, we've certainly seen these with MAOB inhibitors as well. So in that case, I definitely withdraw all the mild effective drugs like MAOB inhibitors. And then you're faced with having to try to change the levodopa. And this is where the use of deep brain stimulation in patients who remain disabled by ICDs, DBS may be very effective, although a small proportion of patients do have these kinds of behaviors with ICDs, and ICD, or at least STN-DBS, has been shown to cause impulsivity. Most patients are able to reduce the dopaminergic drugs, and the studies that have looked at the outcomes with DBS have shown that the majority of patients are greatly improved when they are treated with DBS. So if they're a DBS candidate, that would be another consideration.
Great, thank you very much. And thank you for a fantastic talk about decades really of research in starting the optimal treatment in Parkinson's. We have to move on in the interest of time.